Sure.
And
Speak to Medicaid, incidentally. Sorry about that.
And Todd Williamson, are you with us?
Yes, right here. Todd
Great.
Williamson. I head up the Data Generation and Observational Studies group as a full-time employee at Bayer. And it's nice to meet you, Steve.
Great. And just to be clear, Bayer makes a factor VIII product. And do you have a gene therapy in the pipeline, or I forget?
We do.
Okay, both of those. All right, just so people can put it all together. Okay, so what we're going to do, we're starting about 15 minutes late, no longer than that, but we're going to be able to go till about 2:40. And so this gives us enough time, I think, to have a good, rich discussion. I want to start, look, this is one of those weird situations. We came into this obviously expecting to do a report on Valrox and Emmy. Valrox got paused at FDA, so that kind of had to shift gears. And we end up looking at Emmy and finding in our modeling that it dominates, which means that it's better than the comparator and it's less expensive. We don't find that often. That's not the quadrant of the cost effectiveness universe that we usually find ourselves swimming in. But it still raises some really interesting policy questions that we'll get to. And I know we're all hungry to talk about coverage and pricing and maybe future research. But even though Emmy dominates, sometimes I don't like that economic term, better and less expensive, I want to talk about what we still might not be capturing as part of its clinical benefits. And this has come up a few times around adherence. But I wanted to ask Mark and Brian maybe to start off with, when we do modeling around health, does it capture something like not having to worry about banging your elbow on the table? As I want to say Mr. Jones said, or George, I forget. Does it, the decreased treatment burden and anxiety that, Ms. Sloboda mentioned, and even in our own model, I plucked out this number. Emicizumab and Valrox in a lifetime would prevent somewhere between 3,000 to 4,000 infusions. How do we capture that? What does the field need to do a better job of capturing the full utility of these treatments for patients? You guys think a lot about this. What do we need to tell the field to do better?
I'll be happy to start, and I'm sure Brian will be more eloquent than me. But I think that has been one of our biggest challenges that we've worked through, is we all know that the traditional clinical metrics, which seem somewhat cold, don't really capture or allow us to differentiate treatment. That the way I think about what hemophilia means to me in a bleed is just not the same. I don't talk with Brian about, I had 12 bleeds last year. I had 9 bleeds. And, I talk about the same things everybody else does. I'm able to participate in sports, have a school, go to school, have the job that I want. And so as treatment has progressed, the goal is to push those kinds of worries into the background. We know from other research that that fear is a dominant consideration. Fear of triggering a bleed, fear of having joint damage, fear of having pain. Chronic pain persists in people with severe hemophilia, even though we learn to live with it. So finding a therapy that allows us to think first about living life and second about our hemophilia is what we're seeking. And up until this point, until the arrival of Emmy, my hemophilia governed really every decision. Am I going to go to the gym in the afternoon? Am I even going to want to go to a football game and walk 40 steps to get to my seat and sit in a cramped seat because I can't bend my knee, kind of thing? I mean, it really permeated every decision of life. And Emmy has eased many of those burdens, and gene therapy, we would hope, would take it the rest of the way.
Brian.
Yeah, I totally agree with what Mark said. I think these treatments like ME and gene therapy, you're not really talking about. I think sometimes there's too much emphasis on it gives you the ability to play sports. It gives you the ability to do normal, everyday activities that everybody else takes for granted. Walking a distance, playing a round of golf, playing tennis, swimming, cycling, running after your kids in the park and being able to catch them. I think treatment burden with IV infusions is quite long, is quite large. So there's a large burden in having to intravenously infuse yourself a couple of times a week, every week of every month of every year of your life. And I think when you look at outcomes, I think you look at the number of days missed from school or work, the ability to do normal activities, impact on chronic pain it needs to be measured, the sustainability of your physical functioning. Can you do normal activities and keep doing them? Your social functioning, can you have a normal social life? And your mental health. I think hemophilia and thinking about hemophilia takes up a significant amount of hard disk space in your brain, even without thinking about it. You know, as Mark said, if you go to the gym, okay, I better take my prophy this morning because gym is this afternoon. Or I'm traveling, I'm taking a long flight. Do I switch my prophy day by day? So you do a lot of thinking about living with hemophilia, even subconsciously. I have to say that a couple of years ago, I switched from standard to extended half-life factor 9, and I found that a tremendous benefit in terms of lower frequency of infusion and greater protection, higher trough level. And this year I'm actually now being treated with a gene therapy vector, and that's been a game changer in terms of annual bleed rate of 0, more activities of daily living without any chronic pain, and actually less time spent thinking about infusing. I've forgotten to think about infusing, and also you know, mentally you're in a better place because you're just happier. This is a quality of life we didn't think we would have with severe hemophilia. The one thing you will find with gene therapy is that you will not see the quality of life burden increase in the first year that you might think, because of course the burden of visits to the center is increased rather than decreased, because there's a very large number of visits in year 1 of gene therapy trial. But I assume it'll be the same with a licensed gene therapy.
So you gentlemen, thank you. You gentlemen both know the field of cost effectiveness pretty well, and you know how people want to try to use the quality to capture things that you've been talking about. What's your own assessment though? I mean, do we need what does the field need more? A way to quantify these things outside the quality? I mean, you just saw this group vote on potential other benefits. Is that the best way to do this? Or are there fixes to the quality? I can imagine studies that will measure these things and say drug A is better at it than drug B, but does that actually get translated into the kinds of value assessments that are being used by many to think about fair pricing and other things? Where are we with the technique of being able to capture these things that matter so much to patients? Let me, Richard, I'll come to you in a second. Let's see. Brian and Mark, do you guys have any thoughts on that?
I think some of the more detailed patient-reported outcome measures like PROBE add value there, because you've got a much bigger list of activities of daily living you can look at. But frankly, I also think you also need to look at qualitative data. You need to look at focus groups. You need to look at discussing with people the impact of treatment is having. What we've been trying to do when people switch therapy, and we tend to switch systematically, is we will interview people in groups before they switch and then a year after. So you're actually getting not just the quantitative quality of life measures, you're getting a real sense of what their experiences are if you do a facilitated discussion group. So I think we need a combination of qualitative and quantitative data.
So just to pick up on what Brian said, I absolutely agree that we need the qualitative data, and we need hemophilia specific data. Instruments such as EQ5D, SF36, or the PROMIS tools are generic public health instruments, and they don't really differentiate specifically what matters to patients. We worked for about 8 years to develop a global PRO, the PROBE study. In full disclosure, I'm the PI for that study. And we were pleased that it was recognized, and it really captures those burdens of living with hemophilia. It's important, and we've also published research that EQ5D does not fully capture that when we've looked at how patients rate those specific elements when you understand it in the context of disease. The last piece I would say is, because this is a disease I was born with, and as I said earlier, I've not known normal. This has been my normal. So there is a significant disability paradox that we report a health state that is better than how someone else would perceive that. If other people woke up tomorrow and had the joint issues and the mobility issues and the pain that I have, they would report a significantly worse health state. And so looking at just sort of the crude metrics, they become a blunt instrument. So we really do need to put the qualitative piece around it, as Brian said.
All right, thank you.
I agree.
Richard,
Can I just say that a recent publication showed that disability paradox as being at about 17% overestimation of utility value in people with severe hemophilia.
Okay, thanks. Richard.
Yes, I won't repeat what was said, but I think to Mark's point, there are more tools being developed, such as Probe. In addition, Genentech has developed and validated a quality of life tool called Catch that we believe is more sensitive and able to assess changes in quality of life domains for patients with hemophilia A and their caregivers. So it measures things like decreased anxiety or productivity or even activities of daily living. So we've been incorporating this into our clinical trial programs, and this tool could actually be used across hemophilia. It's not necessarily hemophilia A specific, so it could be used in hemophilia B as well. But we, have developed this and are publishing on this tool as well.
Okay, great. Todd?
Yeah, Steve, I just want to comment. I think there's been several times comments about the need for greater real world evidence. And you probably know the saying, clinical trials show that a drug can work and RWE shows that it does. And I think that's probably an area of focus that a lot of us are looking at in the future. In addition to that, the patient metrics, right? What is of critical importance to the patient? I think we've heard a lot of that today, and it needs to have a stronger emphasis in terms of some of the future research.
Okay, I want to move on just because we've got a lot of other important topics too, but I did want to start there because part of what I think we want to put into our policy recommendations is the need for further research to develop the way to capture precise changes of quality of life in a condition like hemophilia. And it's always, as you guys know, it's always a bit of a struggle between whether you try to figure out how to bake it into the quality or you figure out how to measure it outside and wrap it around as a qualitative component. But we'll want to make sure that the field knows that more work is needed there. All right, let's shift to kind of clinical with a slide into coverage. I think a few people might want to talk about this trough issue. I have a funny feeling that we have a few people who want to talk about troughs and the evolution of our thinking about that and how it relates to both clinical practice, but also coverage. Who would like to take, I mean, we've heard several things about the evolution of the thinking from the 1% to 3 to 5%. Maybe just from one of the clinical experts right now, from your own personal experience with insurance, where is insurance right now with the 3 to 5%, in the United States at least?
Yeah, I could at least start us off.
Sure.
When we first got the extended half-life drugs, our patients started to use them and then started to use them even more frequently because the impact on their lives was so profound. My teenagers were playing soccer, and I had a call from the insurer once a month to ask me why we hadn't gone down to the past dose. They kept giving me these warnings that we were above the dose that had been used. And yet that patient was absolutely refusing to do that. So in other words, having that higher trough meant he could play soccer. And I mean, that's just a paradigm for so many other things. Critical.
All right. Actually, Leslie, maybe I could switch over to you quickly. I don't know. By the way, Leslie is not working for an insurer, but her company looks at the landscape of insurance coverage as part of what they do. And so, but she also has a background as a pharmacist and knows quite well how P&T committees work, et cetera. So Leslie, what do you know about how insurers are dealing with the question of coverage and its linkage to the trough levels? Do you know anything about that?
Yeah, so as of today, when we were you were speaking, and I think it was you, Margaret, who actually this morning was talking about going up to the 3 to 4%. We actually don't hear that. So that would be something that would have to get to insurers, that you still hear about the 1% that you begin to look at. However, when they are looking at, and this goes to a sort of a bigger picture, when they do divide patients up, when they're looking at treatment therapies, and these are for criteria sets, and it's with inhibitors or without inhibitors. And when you are looking at emicizumab, you know, almost all of them, insurers will say patients with inhibitors, we will definitely, you know, cover there. It's really those without the inhibitors that you run into more or less more criteria sets on that. And so that's actually the first thing. The second thing, though, is even in patients without inhibitors, what we're seeing more and more about is it's not just the trough levels, but it's also, have you had a bleed into a joint? And it went from more joint bleeds to down to 2 joint bleeds ever. And that actually is a good sign. It's going to where the whole discussion from this morning was. So it ceased being just, Stephen, to your point, just troughs, but really taking a big look at the pictures where it's going, where the insurers are going and where they have to. But I do believe it's up to you and the community to get out about the difference in trough levels. And Stephen, I just want to take one little second too, because when you were all just talking before about the last topic, one of the things that insurers are going to need is the data, just like you want the data. They want data. And it's so interesting because when you look this morning at the key model inputs and the bleed rates and the joint bleeds, et cetera, it looked pretty, you know, equivalent. People who are well controlled on factor versus emicizumab as far as the bleeds are concerned. So it's going to be up to all those other things you just heard and talked about, is the administration burden, you know, the emotional and psychological. I think that data has to be captioned. So I just want to put in a really, you know, to emphasize that it's not just the medical community, but insurers, et cetera, that are looking for the data to show all those other increases in quality because of the cost.
Okay,
And
Brian, and then I'll
just to add-
circle around, Brian.
Just very quickly, as Steve mentioned earlier, Germany is using a trough of 3 to 5%. In fact, it's the Council of Europe countries, 44 European countries now have a new standard recommendation accepted by all their health ministries that the minimum trough should be 3 to 5%. And they base that on evidence that that trough would give you greater protection for joints. Now, it doesn't mean that all 44 countries are implementing that, and that some of the countries don't have the resources, but that's definitely the recommendation. The 1% trough is a 30-year-old idea whose time should be gone.
All right. Part of my job is to play devil's advocate. So give me some slack. I know from some prior webinar I saw that 3 to 5% isn't where people want to be. They want to be at 15%. I heard somebody say that. And we'll compromise at 3 to 5 until next year, when we'll be back asking for more. And society can decide that it doesn't want to pay for it, and then we can have that conversation. But we should be really shooting for 15%. And on the other side, you've got, if you remember, remember those kind of hokey symbols I had of the patient in front of us and the families around? And think of next year when COVID is requiring more billions of dollars into the health system that states don't have. This is going to create some real problems. So insurers, this isn't, by the way, in hemophilia, as you guys know, there's nothing special about it. This happens in, we looked at a condition called hereditary angioedema, and insurers have to come up with some severity index, how many attacks before you qualify for an extremely expensive treatment. When the right answer is, clinically, you would want to have 0 of these attacks, but they don't do it that way. So there's going to be tension and balance throughout the system. And we'll get to price, don't get me wrong. But if you were to advise insurers on how to come up with a severity of hemophilia score, or whatever it would be that would qualify for certain levels of treatment, what would you tell them? Would you tell them don't try? Or would you tell them here's how to do it? Margaret, Steve, I was going to go to the clinical experts. Yeah, go ahead.
Well, let's take the example from diabetes. I don't think you'd want a situation where your access to therapy would be determined by how many admissions to the hospital for ketoacidosis as a marker of your control. Your marker of control is the control of your blood sugar on a daily basis. And I think there's some analogy here to what we're trying to do in hemophilia. We know that not everyone is going to have a breakthrough bleed when they drop below 3%. And there are people who can spend considerable amounts of time below 1% and still not have a bleed. But if the marker of, if you like, step therapy or getting access to a particular treatment is having to actually have a bleed with all of the consequences of that bleed, it seems that that's the wrong paradigm. We all of these targets are based on the practicality of what we can do and what you can convince a patient or a family to adhere to. So as Brian said, with the old regimens, 1% was really just a minimally effective dose that most people could get behind and the resources of various countries could get behind. We've always known that higher was going to be better. 15% is absolutely going to be better than 3 to 5%. But practically, with the agents that we have in our hands to get us to that levels is a very burdensome regimen for a family. So that's where gene therapy starts to raise the specter. So we always have to be looking for new tools to get us to the new level of control that we want to achieve.
All right. Let me pitch it over to John Watkins, if I may. Brian, I know you wanted to say something, but John, again, is, in a sense, John, are you officially still with an insurer? Can I say that?
Yes.
Or are you, okay.
Yes, I am working half-time for an insurer.
So reflect
we
on a
should-
couple. Reflect on a couple things. I mean, how do you think the coverage criteria are going to be written in terms of trying to decide whether there's a threshold of severity that would allow coverage either for ME or for gene therapy when it comes to it?
Yeah, and give you a contrarian approach. We actually do not have a threshold currently for ME, are not planning to implement one. What we did when we started coming into this space was open a dialogue with our local hemophilia treatment center. I had a resident who did that as a major project year before last. We made multiple visits to them, had some very good conversations, and concluded that the best approach was to work with them and let them make the patient level decisions. Having learned from our conversations with them that they take a conservative approach. They don't, for example, they would not put a person on extended half-life factor without a full analysis, including a pharmacokinetic study. So that's, we're not really looking to micromanage, and I think that the future is to get to where providers are doing this. And of course, the cost of the medication, if we can prevent that from getting higher, that helps.
Right. I want to somehow, and this is difficult, I want to somehow ping back and forth between the ideal and the real world. The real world includes in the United States the factor that, so to speak, that an insurer who has easier coverage criteria may feel like they will attract more patients with hemophilia, and therefore they can't be the first insurer to have no standards for trough or whatever it might be. I'm not saying that that happens all the time or even frequently, but that kind of thing is a part of the free market landscape that we deal with in the US in other conditions, certainly. So, and Leslie, I guess back to you, because we'll, in our policy recommendations, we usually call them policy perspectives, but we're going to want to say something about what is reasonable in the given landscape for what payers would consider to do for having any criteria related to documented history of specific types of bleeds, the things that you were mentioning, the bigger package of things. Are these coming through as criteria sets that payers will adopt, kind of everything from some definition of severity linked to presence of inhibitors or documented history of bleeds? Or do you think that it's possible for payers to not do that kind of management?
I think it's both right now. I think it's all of the above. So there are definitely, again, the trough levels are out there as far as metrics to use. But as I said, we see that there are definitely criteria sets that it's approval for a mild to moderate patient, but who's not controlled, all the way to, as what John said, that, conservative hemophilia treatment centers that look at every patient and do pharmacokinetic studies. I think, Stephen, it was to your point, Stephen Pipe, I think it was to your point that it was, you said something very interesting. You said that, 15, a threshold of 15, you'd be looking at. But what would happen, how insurers are going to look at that is to get everybody to 15, even if not everybody needs it. And you said that, which we all know, that not everybody needs that level, that's a very expensive proposition. So I think, Steve Pearson, to you, what we really have to figure out is who, if you could, who actually needs that, who doesn't need that, and allow for the patients who need more in order to stay controlled, to get as much as they need, versus those that don't. We had this discussion, by the way, Stephen, a lot of times when I was back, I was for 25 years, I was vice president of a health plan in Massachusetts, the pharmacy side. And we had this discussion on normal medications. We had them on blood pressure medications and diabetes. And there could be a drug that may not have totally gotten everybody to where it was, but it was so much less expensive that try it. And then if it doesn't work, you get to the next level. And that's what this does remind me of here. One thing I do want to put out there, all the insurers that we consult with and our clients have stated that, I do have to say, Enucizumab is a lot more expensive than they thought it was going to be. I think that they felt that average-wise it was going to come out at around 450 to 500,000 a year, and what they're telling us a lot of times that they see it above the 600,000 per year mark. I don't know if it's because we're treating older patients or didn't expect heavier patients, but there actually they are finding that the cost of it is more expensive when they average it out than they thought it was going to be. So I needed to put that in there also.
Yeah, we'll come back on that. At least some of it may be wastage. I wanted to ask about that again. Stephen Pipe?
Well, just to come back to Leslie's point, I would say exactly what she's describing about the phenotypic, teasing out the phenotype of the patient is what happens at the hemophilia treatment center level with every patient. And so I think we all recognize that patients need perhaps different targets or different tools to get them to those different targets, even at different phases of their life. So what we're striving to accomplish in an infant versus a school-age child versus a 50-year-old could be very different. And even in the 50-year-old, that target could vary depending if they have an incremental pathology, like something like cardiovascular risk factor, and have to go on an antiplatelet agent or something alike. So when we're talking about these targets and troughs, I think it's an improper assumption that we're just saying that the entire population has to immediately be bumped up to some target, and so then you need to budget that. That's not going to happen. But we want the ability to be able to manage the patients according to their phenotype and their life challenges ask for.
I'm going to try to adopt a bit of a rapid fire kind of question approach for a couple of things related to coverage so that we can then move on to some of the pricing issues and how it affects access. So again, thinking just of Emmy for now, I want to kind of quickly take a survey. Do we think that in terms of the perspective on what we would advise for coverage is, should whether there are inhibitors or not play a role in whether it's covered? Yes or no? Stephen?
So you're asking me whether
yes. Should payers have a consideration of coverage for Emmy, dependent upon whether the patient has inhibitors? Yes or no?
I'd say no.
Okay. Anybody think differently? Okay. Documented history of bleeds? No. So a patient who's 20 who's had one bleed in their life should be able to get Emmy?
Absolutely.
The
goal of their existing therapy is for them not to bleed. So the choice of whether they're on Emmy should be dictated by whether that's the right treatment for them at that phase of their life. It shouldn't be dictated by the fact that they couldn't get control with their existing therapy.
This goes to my previous comment earlier in the day, Steve, that I should not be asked to bleed X number of times before I can get to an optimized therapy. Joint damage occurs with the first bleed and accumulates over a lifetime. And whether I am a newborn and starting out as a primary treatment, or whether I'm starting out it as a 40-year-old, you either want to halt or to prevent that cycle. And to say that I've got to bleed a half a dozen times and have established, and then what you're saying is I need to have established joint disease and joint damage that's going to be with me my lifetime before I get access, that's just really wholly unacceptable to patients.
So is there no way to clinically decide someone is mild enough on the hemophilia spectrum to not require the most expensive intensive treatment?
I wouldn't say that. But it depends what you mean when you're saying mild. So you're talking about amongst all your severe patients, can we tease out someone who has a slightly milder phenotype? That's a very dangerous prospect. We would not do that. So if you have severe hemophilia, you are going to get the standard of care treatment according to whatever regimen is going to work best for you.
So do you use the factor 8 levels to decide what's a severe person with severe hemophilia?
As a starting point.
Okay. I mean, I think you can understand that insurers are not just hemophilia, they do this to diabetes, they do it to, I mean, to be fair, they will search for ways to decide that we have outliers, especially doctors who will overtreat with very expensive medication, patients who really don't need it, quote unquote. So how do we help insurers come up with language that can find the sweet spot?
So I just want to make sure that we're not out of scope for what this review actually looked at, because in terms of looking at the dose and whether it's standard versus extended or higher trough level, I mean, what we did decide was that prophylaxis relative to imicizumab is cost saving.
Right.
So if we're looking at what is the current standard of care, then the issue isn't picking sort of a wildly expensive high cost drug. I mean, we can discuss later whether we think the price is right. But the issue is making sure that we allow clinical experts to be unfettered in making the decision what is the right therapy for that patient. And forcing a patient to go through step therapy and putting them on a trajectory of joint disease or pain or other disability does not make sense in light of the votes that we just took this morning.
Right. No, I hear what you're saying. That's why I'm trying to ping back and forth between that and the real world, where I think the idea that doctors have unfettered ability to prescribe whatever dose to whatever patient they want is not really the reality in any other area of the American health system that I've seen recently. Oncology a little bit. So we're looking for, now we'll get to the price because that's a big part of this, but insurers are looking for guidance on reasonable ways to craft a cost-effective approach to this. Now, as you said, if it's going to save money, it will. But I think some of the payers, as Leslie said, are finding that with wastage, their actual costs for ME are much higher than even we incorporated into our model.
So
the wastage is a different issue, but frankly, you can't overdose with imicizumab because it's a fixed dose of prophylaxis, unlike with factor 8. But in terms of unavoidable wastage because of the potencies and vial sizes and so on, that's an entirely different issue, which should be sorted out.
I mean, a very effective cost management tool would be for insurers to universally give patients access to hemophilia treatment centers and the pharmacy benefit programs within those centers. That's demonstrated to save. Patients can't doctor shop for their HTC. I mean, it's just virtually physically impossible, nor is it really possible to doctor shop an insurance policy. It is next to impossible to figure out whether your product or your HTC is covered within a plan when you're signing up in the plan window. They just don't give you the list of the specialty drugs. And if I was trying to make a decision on whether drug A or B and at what level it would be covered, it would be virtually impossible for me to do that as a patient during the open enrollment period.
Good point. We're going to come back. We're going to note that. Okay, I'm going to pivot to some of the pricing issues. Brian, in Europe, everything's less expensive. Why?
Well, I think there are a number of reasons. I think in the United States, you're paying for unrestricted choice. there are probably about 45 factor eights in the market, and I think the USA likes to have them all available. So you're paying, I think, a premium for unrestricted choice. Your systems for purchasing are different. I think you have a lot of potentially add-on fees, taxes, handling fees, distribution costs, delivery costs, home care company costs. And I think you have the lack of a competitive procurement system. Now, if you have every single product available in the system, then there's no incentive to any company to lower the prices. What we tend to do in many European countries is we might have all the categories of products available. We might have standard half-life, extended half-life, ME, and gene therapy, but we limit the number in each category. So you're actually developing competition. If you look at the CHEST data from Jamie O'Hara about 5 years ago, when he looked at the average annual cost of prophylaxis for adults in the big 5 European countries, Germany, Spain, France, Italy, and UK, in US dollars at the time, it ranged from $120,000 to $350,000 per patient per year. And those costs have probably come down since. But even within Europe, when we did a fairly extensive survey of the pricing models in 38 countries 5 years ago, we found that for recombinant factor concentrates, there was a 4-fold difference within Europe between the lowest and the highest prices, and a 7-fold difference in plasma derived. And you might think, well, you've got, very wealthy countries and quite poor countries in Europe. That's the reason. Absolutely not. The reason was countries with different systems. So, for example, in countries where you've got one unified procurement system, where the doctors and patients are formally involved, you tend to get a much better outcome and lower costs than if you've got a variety of systems. Romania, for example, which is the poorest country in the EU, pays one of the highest prices because they have 33 separate procurement systems just for factor concentrates.
Yeah. So as I understand it, it sounds like the Europeans negotiate and they're willing to give up full access to everything on the market as part of an approach towards affordability. We heard from, forgive me, the doctor who's the head of the National Hemophilia Foundation, who called strongly for full access to all available agents and the ability to prescribe them. What do the clinical experts perhaps feel like? Could you get away with a world in which someone was able to achieve a half or more off the price if they negotiated, and by that meant that they got to pick a winner in the factor 8 category, a winner in the gene therapy category, like they do in autoimmune drugs, other areas of medicine? What do you think?
Maggie, why don't you take that one first?
Thanks, Steve. Well, it makes sense. I've heard Brian's information on many occasions, and there's a lot of good to be had. In my center, we started with the first product available for the extended half-life, and that's the one that's used. We have an occasional patient use other drugs, but it was quite good. We've had no big problems. I think there's some positives in that. Of course, some patients, there's choice, and that's part of the problem. That's dictated by all of the governing agencies, our federal hemophilia program, so we have to include that. But by and large, we're using 1 or 2 products at my center for the extended half-life, but primarily 1. So I see that as a potentially reasonable approach. There's always going to be exclusions and problematic decisions, but if we use something like you have to have fewer than X number of bleeds, I know that's not perfect, but bleeds don't, as we've already heard, don't exactly equate to trough levels, so that different patients may have different experience with different drugs. So it's very problematic, but I think overall, one could say that 1 or 2 drugs might be reasonable. I'm sure I'm stepping on somebody's foot, and that's why Steve asked me to answer this.
Steve, go ahead.
From about the early 90s until, maybe even the mid 2000s, I could have got by writing a single prescription for factor 8 products at my center. No problem. Almost all the patients would have been well served. That's not to say that people might not have had historical preferences, etc. However, as the complexities of the market have changed, the ways that these molecules are manufactured, some of the differences between the products, and then now the extended half-life molecules, we've illuminated some interpatient variabilities that we didn't appreciate before. I used to compensate for that by just altering dosing regimens and maybe the interval. But I shared the example earlier today. I had a patient who went on an extended half-life and he got none of the PK benefit from that extended half-life molecule. I switched him to a completely different EHL, different mechanism of action, and he had a superb reaction. Why? No idea. But there's a good example where I needed that justification to push for him to get access to that drug.
Yeah.
So I don't think.
And I had the same example and put him on emicizumab because of where his mutation was located, he did not respond. Sorry.
Well, let me jump in. I'm going to need to move us forward just because of the time we've got left. But as a comment, I know because this was partly in an article written in 2018. Rebates and the PBM world are coming to hemophilia. And so one way or the other, we're going to see restricted choice as a compromise for lower prices. Supplemental rebates and Medicaid, this seems to be at least one of the options. The other option would be a centralized purchasing situation like some European countries can have. That will be one way to manage the costs. At the end of the day, and I know that anytime people are going to talk about cost, it's going to feel like Scrooge. But I want to take a couple of kind of radical ideas. One is for the manufacturers and for the patient groups and everybody else, if we were talking about $500,000 to $800,000 a year for any other treatment, for any other condition, we'd be saying it's too expensive, just flat out too expensive. So now because Factor VIII has been there for a while and we've got Emmy on top of it, it's like we're on stilts on top of stilts. The system is going to say, well, and even a drug like Emmy is cost saving because it's only $600,000 a year. And let me just read you a quote from a patient group that came out just this week. And it says, our aim is to gain access to life-changing medicines for all around the world. To do this, we need everyone to change. We need to expose the unnecessary cruelty and suffering being experienced by patients with, and I'll say hemophilia around the world. Can you help us? We are looking for people from all corners of the world to make this happen by lobbying the drug manufacturers for change. Their current pricing expectations make these drugs unaffordable for healthcare systems, leaving half the world untreated or undertreated. Some blank number of people in the world suffer from this, but only half have access to the right doses of this life-changing medication. These amazing medicines have the power to help correct the gene fault, which causes the illness, and stop a slow and excruciating death, et cetera, et cetera. This group of campaigners exists from people from all over the world, and they give a list of about 30 countries. So let me start with the patient groups. I went to the websites of the National Federation of Hemophilia, the World Federation of Hemophilia. The word price does not exist on those websites. Cost does a little bit, no price. No criticism of pricing of any product exists in those communities, nor do I find it, and I'm not sure if it does, but I haven't looked, honestly, I'm guessing, but I'm not sure what the professional societies have said about this. What would we do if we said, just stop, if we're going to use more Factor VIII to get from 1% to 3 to 5%, how about the manufacturers agree not to charge a flat rate? Whatever it costs to get us to 1%, let's make that the cost to get to 3 to 5% or 10%. Why do we need to keep going up just if we use more medication? Can't we have a bundled rate? Are there other ways we can approach this? And where are the voices coming from that are going to address the fundamental problem that we have a cost structure for hemophilia that is sky high compared to almost any other condition? Lots there to talk about. Brian.
I think it's unfair to say that the patient organizations don't raise this issue. In fact, I on behalf of WFH, I've run tender procurement courses in over 30 countries around the world where we bring together health ministries, doctors and patients to look at this, including cost, including pricing, including different models. I think with the advent now of emicizumab and with gene therapy coming down the tracks, it's no longer easy to compare directly 1 unit of SHL with 1 unit of EHL with 1 milligram of emicizumab with the impact of gene therapy. So I think we're inevitably going to be going down the road towards looking at an annual cost per patient. And what you suggest, Steve, might well be more of a reality in future, where you say, look, this is the annual budget we have for each patient, and how much treatment can we get for that in terms of the cost per unit of SHL or EHL or emicizumab. And I think that system is already going into place in some countries, that there is acute sensitivity to the cost of treatment in many countries in terms of hemophilia care.
Okay, quickly, we'll go around. Mark?
Yeah, so first, I'm not sure it's my place to apologize for the cost of my disease, but I absolutely grant that it's expensive. But don't ask me to say whether I'm worth $1 million or $200,000. I have written widely and spoken widely, both in my tenure as president of WFH as well. I mean, it's the clear statement that I make is the safest, most effective drug that's not available or no one's willing to pay for is of absolutely no benefit to me. We are highly price sensitive, and we recognize that the prices need to be set. In my last plenary as WFH president, right at the dawning age of extended half-life products, I called on the companies to pass on the operational savings that would occur with the efficacy that was generated in the new technology, and said we needed a new pricing model. It was not sustainable if we could not, if we wanted to reach the rest of the world, that we should be pricing based on on volume, not on margin, and that it really was inexplicable to understand why prices are going up for older technologies when we're going forward, and it leaves no room for us to get any headwind to bring the new technologies forward. So, I mean, perhaps we've not done a good enough job of leaving those messages there, but what the work that Brian's done, the things that I've done, are in print, they are on tape, they have been in press releases, and we've talked about them, and we are committed to that. We do not set the price, but we are highly mindful that we are expensive, and we want to be good stewards of precious resources. We are all the more anxious now in the advent of COVID, how governments are going to reallocate costs and where they're going to find the money to sustain, let alone advance in areas that we know there need to be advancement.
Right. And apologies if it sounded like it was a challenge. It was just a note that I think what people say in public and what appears on an organization's website are often two different things. But that means something when it's not on the website nor available on any of the advocacy subsections of a website. And I want to turn to the drug companies too briefly. We're talking about a cure for hemophilia. When I go back all the way to that first slide, I said, why are we here today? What happens when the FDA approves a drug? That celebration. I think we all feel like we're within earshot of a cure for hemophilia. That will be one of the hugest, it'll be one of those epical moments. What are we going to feel like if that cure costs $7.5 million, which is what a cost effectiveness model said? I know the companies are going to say, oh, we'll be generous. We'll do it only for $3 million, and that's only worth $3 million because of the cost that it's offsetting in the health system in some sense. So why should a cure for hemophilia cost more than a cure for blindness or a cure for sickle cell disease? Is that fair? Do we want to say that that's the right thing to do for a cure for hemophilia? Because it's such an expensive disease, we should be willing to pay more for a cure for it. Is that right, Wing-Yen Wang? Apologies if I'm mispronouncing your name, which I know I did. And I'm putting you on the spot, but why would you want to price your gene therapy so much higher than any other gene therapy? Is it just because you're going to help people save some money?
So I think that, first of all, we're fairly early in the game, and we are certainly committed to exploring all the innovative payment solutions. But more importantly, we're committed to responsible pricing and the overall healthcare offsets that we can contribute to. So we are working with a number of institutions to help get to that process. And we're also exploring options such as outcomes-based agreements to really address potential variability in clinical response in different situations. So I think we do want to be responsible, we want to be cognizant, and we do want to also ensure that clinical benefits are taken into account.
I understand I'm putting you all in a difficult situation by asking this kind of question in a public meeting. But there was a quote in this Kaiser article that said that hemophilia is a classic failure of competition. None of the drug companies want to talk about taking a penny off the price because then they're afraid that the next guy will take a penny off their price. And so competition fails, and instead they spend money to compete to woo patients by sponsoring summer camps and lots of other things, which are great, but which are an attempt to build use through a different approach than seeking a more affordable price. So I just want to throw it out as a challenge, and I'm doing it in a very unfair way because I need to shift to the end of this meeting by saying that there's a lot of celebration ahead and a lot of work to be done so that more patients can benefit from these wonderful treatments. I don't know anyone in my own family or even like broader friends other than Mark potentially who has hemophilia, but I sense the progress. I sense the excitement and the importance. And I think we all have a lot to do to try to make sure that it can come through in a way that is not just affordable, but sets a precedent for how we can all contribute to a better healthcare system that will be affordable for everybody for the next cure after that. Because if we treat them all as a way to kind of capture all the downstream costs and put a bow on top of it for the innovator, I'm afraid we won't get there. So that's my own personal soapbox. My apologies that I got to do that and didn't give many of you much of a chance to speak today. But now I would like to give you all a 30-second chance to have a final statement before we wrap it back to the New England CEPAC. So think of 30 seconds. That usually means one sentence, not even with much punctuation. And it can be the one thing you want this meeting to remember. It can be the one thing you want to ask somebody else to do. You could turn to the payer, you could turn to the manufacturer, you could turn to the clinical, one thing you want them to do, or some combination. Leslie, why don't I start with you?
Yes, so I can be quick. That one of the things that we need, that payers need, insurers need, is definitely the data. And that it sounds like there's a lot of data that's not being captured, and that you want it too for the medical end of it, the clinical end. But remember, as Steve said, there's only so much so many dollars out there. So when I get off the phone here, I am talking about cystic fibrosis. And next week I have a sickle cell disease. And there's Pompe and Gaucher's and DMD and all of these terrible diseases that really there is something going on in high prices. So I say to you, get the data out there. And once it's there, we can look and see what a good price, a reasonable price is for hemophilia.
Thanks very much. John.
This is a complex disease. Treatment is nuanced, and furthermore has to be considered in the light of the patient's circumstances, their life, their objectives. That's why the provider needs to make the patient level decisions, but we need to be able to work with them. The data is a piece of it. If we can connect those dots, I think we can do a lot better. There's just too much fragmentation still out there.
Okay, thank you. Todd. Oops, you're muted.
Sorry, yeah, sorry, Steve.
That's right.
I think the big thing for me today was having heard from the patients. That one really drove it home for me that the focus for all of us should never lose sight of the fact that it's doing what's best for the patient. And hearing them talk today really underscored that for me in terms of if we keep that at the focus and aim to do the best that we can there, then I think we're going to do better than we would in terms of taking any other approach.
Okay, thank you. Richard?
Yeah, our key takeaway is that Hemlibra, which is backed by the HAVEN program, which is the largest clinical trial program in hemophilia, is a safe and effective treatment for all patients with hemophilia A across ages, with or without inhibitors. And the body of literature and the totality of evidence suggests that Hemlibra is cost savings compared to current therapies, offering value to patients, providers, and the healthcare system.
Okay, Wing Yen Wang.
We do want to take this opportunity to be innovative, to do our pricing responsibly, to make access to patients who will benefit from it. And we will do what we can, and that was best for the patient community.
Okay, thank you very much. Maggie?
Okay. I have a little poem. Hey, can't you see? They just want to be free. Free of factor VIII infusion, free of fear and exclusion, free of bleeds and contusion, to live life without illusion. They just want to be free. So what is the confusion? Is life versus cost the collusion? But how can cost of infusion make life quality an exclusion? How is rejection by insurers a solution? Is life without fear a delusion? They just want to be free. But Emmy can set them free. Free of IV infusion, of fear and exclusion, of bleed and contusion, of living in illusion. This is the free they want to be. Thank you.
How long did it take you to do that? You muted yourself. How long?
Not very long. I love to do that. Maybe
All
an
right.
hour-ish. I love to do that. I would rather write songs than whatever. Okay, I'll be quiet.
Thank you. Wonderful. Stephen?
Well, how could I follow that? But that's
tough.
the challenge of working side by side with Maggie over a long time. I've been treating hemophilia for 28 years. I've never felt as empowered as I am today in the clinic. From the time I meet a family who has a newborn, and the treatments that I can offer them, the way that I can manage a school-age child or an adolescent to get them through a sports season, to transition those young men into the adult clinics with the aspiration of potentially having, really healthy joints. It's never been a more exciting time. And then with this prospect that what could be awaiting for them at age 18 and above is a curative gene therapy. These are wonderful days.
Thank you very much. Brian?
Couple of quick thoughts in 30 seconds. I think we need to integrate patient relevant outcomes in all of our discussions. I think we should not forget the future continuing important role of hemophilia treatment centers, even in an era of gene therapy that'll be needed more than ever. I believe that cost is not what's important, it's relative cost. So it's looking at the cost of gene therapy in the USA is relative to the cost of emicizumab or factor. So you look at the whole paradigm. I think engagement with payers from the patient and clinical community is vital, as we're doing today. This is a really good process. And in terms of moving towards better therapies, transformative therapies, and moving towards a cure, I won't quote a poet, but I quote an American president. This is an idea whose time has come.
Thank you very much. Mark, last word.
I was born at a time when factor hadn't even been discovered, cryoprecipitate hadn't been discovered. Over my lifetime, I have seen enormous transformation, and we're not at the end of the road. So today is an important step in setting a path for the future. Thanks to ICER, you have given us an opportunity and a receptivity to accepting patient-important outcomes and understanding that what's relevant to patients can be a differentiating feature. Sort of my challenge or message is that the companies in particular need to get on board and build patients early in and publish the data early so that it would have been available for you today. ICER has been receptive in accepting indirect evidence and other, but we need it directly, and we need early engagement, and we need it published with the trials. My last word is, it was just to echo what others have said, is HTCs are central to all of this. They can be part of the solution in the optimization, utilization review, the management, the pharmacy program. There are savings to be had just within the structures that exist today, and then we can work on other components.
Folks, ladies and gentlemen, thank you so much. I apologize that we had to kind of squeeze it into a slightly shorter time than we wanted to. And I know we could have spent 2 hours and actually gotten a lot more out of this. And Brian, I guess you kind of made reference to this, but in the US context, this is a unique chance for us to hear from the patient perspective, to weave it into material that payers and others will wrestle with. And it's a high responsibility for us to do a good job to capture that. So I tried to cover a lot of territory between kind of what payers are thinking and how that might be woven into coverage criteria. I think we got a lot of good perspective on that will be helpful. We obviously talked about the pricing. And then Mark, your point too is we also want to be a force for getting the right kinds of evidence to make sure that we are evaluating the value to patients. And so we may want to try to figure out how to write something together after this to make sure that folks are aware of our longer term needs, because it's going to be an exciting next few years, but it's not too late to build in the kinds of outcome measures that will really help us capture how wonderful these can be for patients. So thank you to each one of you and to you as a group. Let me hand it back over to the chair of the CEPAC because he will have to do a very quick kind of go around just to see if anybody does have a last statement. We can run a little bit past 3, just recognizing that some people will have to leave. But then I'll have, again, just a goodbye at the end. But Rob, can I hand it back to you just to see if any of the CEPAC members would like to have a final statement?
Sure. Given the constraints on time, it might be prudent for folks to use the raise hand function. And if they do, I can call on you.
Rob, this is Jean. I can't raise my hand, but I just want to say that this was one of the more hopeful CEPAC meetings of my tenure, and I so appreciated the patient point of view. I want to thank them, even though I can't see them.
Thanks, Jean. Rebecca.
Thank you. And this was my first meeting. I'm new to the CEPAC, and I was also very struck by, in particular, the testimony from people with lived experiences. I think the takeaway for all of us, as we've talked about, is the importance of carrying some of those themes. And Steve Ping said so beautifully about spontaneity of life. That's an important quality measure we need to figure out as a patient-reported outcome to carry forward, along with the life-changing that the 5-year-old's mother talked about, the lifestyle boost. We heard that again and again, but that spontaneity of life and how can we capture that in a meaningful measure, I think is a job for all of us in terms of the excellent policy roundtable. How do we quantify that?
Thank you. Claudia. Claudia, are you on mute?
Yep, sorry about that.
I was looking at the camera.
Oh,
now I can start? Okay.
Go ahead, Claudia.
There I am. Okay. Now, I just want to comment that I've been on CEPAC for a long time. And what struck me in some ways from this meeting was more than I think any other meeting that I've been on is the difficulty of designing randomized controlled trials that can take into consideration all the patient-reported outcomes and contextual factors that we need to consider. And I think that CEPAC really showed and shined in its role of taking all those considerations into our deliberations for this evaluation. And I think it's made a big difference.
Thanks, Claudia. Okay, Claudio.
All right. Thanks for that. And I just want to echo some of the comments that were made today. I really appreciate the way that we tackled the other considerations, contextual factors. I think that framework is so much more honest and responsive to the patient experiences. Often we get these really compelling stories, but it's hard to kind of purposefully inject those experiences into our deliberation. And I think the framework that we used today was fantastic. And I just want to really reiterate one of the statements made by Ryan, who said, when we think about costs, and that we shouldn't just think of costs coming out of his pocket, but the opportunities that could be coming into his pocket when we consider the context around these interventions. So thank you, ICER. You guys did a fantastic job again, and I really appreciate being part of it.
Thank you, Claudio. And I don't see any other raised hands, so I will make a final comment that I was really struck by the courage of our patients who were able to relay their experiences and the way that they faced the challenges with this disease. I'm amazed by the poise and the way that they've faced this through their lives. And now we're at a very hopeful time, as Steve said, and the future looks very bright. So thank you all.
And so for me, a thank you to the New England CEPAC. You guys did a fantastic job digesting the information. Don't be surprised if in a couple of years we have some more exciting news on hemophilia treatments and are back here with you to look at a gene therapy or two and maybe some other treatments as well, who knows. But this has set a great foundation for that. And I can't say that without thanking again the patient experts, the clinical experts, and those who also provided comments. Because we listen and learn all the way through the report process, but the richness of what we can have in these public meetings with all of it at once, it really is very influential in the right way. I think it helps lend perspective. Poise is the perfect word to use, and the contributions to the thinking, because we are going to celebrate in a couple years, I hope, and yet a lot of these issues will still be on the table and we'll have to wrestle. My only dark lining to the cloud is that we've all seen how the American healthcare system manages this kind of problem. It creates barriers to access. It uses the free market to create shadow prices, one rebate versus another, switching one year to the next. It has a way of heading off in that direction that is hard to corral and bring back. And I think the best hope we have is to try to grab hold of it. And that means having the patient groups and the clinical specialty societies reach up and say, this is us. This is us too. And we need to make sure that we own part of this. We're not going to apologize for it, but we're going to own part of this process and have a voice in it. And that means doing it right so that it can be a fair price and a fair access linkage that will allow us to do the right thing for this cure and for the next one and the next one after that. So it's great to have that problem, if you will, but it is a problem. And I think having these kinds of public conversations is one of the best ways we can try to move the ball forward. So thank you again to everybody. Wow, it's 3 o'clock. How'd we do that? It's exactly 3 o'clock. It's still snowing here in Boston, wherever you are. Clearly where Tara Lavelle is, it's sunny and 85 degrees. But wherever you are, please stay safe. Wish the best for our country over the coming months. And just, we appreciate all of your contributions very much. Take care.
Thank you.